First, our patient is an Indian female with the age of 55 years old. She has normal body weight, height, and BMI. She admitted to the hospital due to the syncope attack in the morning of 24th March while working. After attack, she unable to lift left upper limb and unable to walk. She also associated with fever, chest pain, shortness of breath, upper respiratory tract symptoms, and slurred speech. Before that, she had severe headache on the right side. For the history, before this, she had diabetes, hypertension, and bronchial asthma. Previously, she admitted for upper respiratory tract infection with bronchospasm and electrolyte imbalance. For the family history, her father has stroke. All 5 siblings have diabetic mellitus. Her eldest, second, and youngest sibling also undergone coronary bypass surgery. For the social history, she works as a teacher and she does not smoke or drink alcohol. For the past medical problems, she had metformin, gliclazide, Mistard 10 unit, and neurobion for the diabetes, tranexamic acid and medroxyprogesterone acetate for fibroid, amlodipine for hypertension, and lastly simvastatin for dyslipidemia. Patient claims that she compliant to the medications and know the indication and when to take it. In the afternoon of 24th of March, she admitted to the hospital with the symptom of left side weakness, headache, giddiness, and tachypneic. Symptoms of left side weakness and giddiness may indicate the stroke. Moreover, she also showed uncontrolled diabetes based on the high level of blood glucose and abnormal HbA1c. Then, she was given IV potassium chloride, IV hydrocortisone, oral aspirin, and extrapid 6 unit, and went for a CT scan. At 6 p.m., results from CT scan show hyperdense over the right occipital region and no evidence of thrombosis and no bleeding. Hence, she diagnosed as posterior circulatory infarct. Antihypertensive were withheld and normal saline, cadiprin, atorvastatin were given. Blood glucose monitored 4 times a day and served extrapid 6 unit if level more than 10. On 25th of March, patient was alert and conscious. There was no complaint of SOB or chest pain. She was admitted on the bed. CT brain indicates right alarming infarct. Due to her uncontrolled blood glucose, monitoring of glucose 4 times a day continued, and addition of 12 unit insulatard and entrapid increased to 8 unit TDS. High ESR and fever may indicate infection, therefore blood right result were asked to trace. Hyperkalemia was observed as the level dropped from 2.8 to 2.7 and to 2.3. Fast correction with 1 gram potassium chloride was done. However, another fast correction with 2 gram potassium chloride was given again due to drop of potassium level after first correction. Then slow 1.2 gram of potassium plan to start for keeping potassium at level more than 3.5. Continue to withhold antihypertensive and correction of hypomagnesemia by giving 1 vial of magnesium sulfate. On the 26th of March, patient complained about headache. Paracetamol 1 gram stat was given when temperature spiked. IV augmentin 1.2 gram and oral bendrobial 2 mg were planned to start. Blood glucose remained uncontrolled, therefore insulated insulin increased to 40 unit and diuretic diet advice was given. Slow potassium and fast correction of potassium continued and monitoring of bills after correction. On the 27th of March, patients show sign of infection as increase in body temperature and high CRP levels were observed. IV augmentin was continued, and increasing trend of potassium level was observed after the correction. BP of the patient was still uncontrolled and monitoring of BP was continued. The red color reading showed abnormal value of the lab investigation. As we can see, the fasting blood sugar and HbA1c was abnormal and it indicated uncontrolled diabetes. Next, the reading for the full blood count was only available for 34th and 35th of March. Therefore, monitoring of full blood count should be done constantly when there is sign of infection. Next, for the liver function test, the total bilirubin and albumin was slightly deranged from the normal. For kidney profile, the serum creatinine was lower than the normal range. This may be due to the aging problem. Besides, hypokalemia was observed as the level of potassium was lower than the normal range. For lipid profile, the HDL and triglycerides show slightly different with the normal range. Lastly, we can see that the patient have mild hypomagnesemia and high CRP value may indicate sign of infection. And these are the medication that the patient currently taking.
The first diagnosis is uncontrolled diabetes mellitus with potential hyperosmolar hyperglycemic non-ketotic syndrome or HHNS. The patient's sign and symptom that supports the diagnosis of uncontrolled diabetes is high blood glucose level upon admission for 3 consecutive days, high HbA1c that reflects the average blood glucose level for the past 3 months, history of electrolyte imbalance and infection. We suspect that patient may have potential HHNS. According to CPG, the diagnostic criteria for HHNS are hypovolemia, marked hyperglycemia, blood glucose more than 30 mmol per liter, osmolarity rate more than 320 milliosmol liter per kg. However, patients do not have these criteria, but monitoring is required. Patient was also admitted due to incidents of stroke. Therefore, treatment should be given accordingly. Based on the CPG, for acute ischemic stroke, it is important to avoid hypoglycemia. Next, use insulin if OAD cannot achieve target. In this case, atropine and islatard is used. The target range should be 7 to 10 millimole per liter. If the patient is diagnosed with HHNS, the recommended treatment would be to continue the anti-diabetic medication to normalize the blood glucose. Next, replace fluid and electrolyte loss to normalize the osmolality. For example, give 0.9% normal saline solution and potassium supplement either via oral or IV route. For monitoring of drug therapy, we can monitor blood glucose level so that it is in normal range, monitor electrolyte balance, monitor hydration status by observing the skin turgidity or IO chart, monitor lab investigation, and monitor signs and symptoms of complications such as neuropathy. In this case, Neurobion is given to patients. In a side note, uncontrolled diabetes can also lead to diabetic ketoacidosis or DKA. However, it is not common in type 2 diabetes. We can conduct further diagnostic tests to differentiate DKA and HHNS. Lastly, the significant difference between these two is the presence of ketone. Therefore, breath ketone tests can be performed.
Next is ischemic stroke. For signs and symptoms, there are syncopal attack, severe headache on right side, unable to walk, unable to lift left upper limbs, and lastly, slurred speech. For the risk factor, the patient is having the family history of stroke, diabetes mellitus, hypertension, and hyperlipidemia. For treatment, patients who are not receiving thrombolysis, early aspirin therapy can be given within 48 hours with a dose ranging between 150 mg to 325 mg. According to the UCAN formulary, soluble aspirin 300 mg 1/10 OD can be given. Following the initial dose can be reduced to 75 to 100 mg per day to reduce the risk of recurrent stroke. And according to UKN formulary, cadiprin 100 1/10 OD can be given. Lastly, for the monitoring part, we can monitor for the platelet count and monitor for gastrointestinal bleeding. PPI can be given as prophylaxis in high-risk patients, and we should monitor for signs of allergy.
Next, let's talk about the patient's dyslipidemia condition. As the patient had dyslipidemia and stroke, we recommend the switch of a previous medication of simvastatin 20 mg, which is a moderate intensity statin therapy, to atorvastatin 40 mg, which is a high intensity statin therapy. According to Malaysia's CPG and several journals, atorvastatin given as high intensity statin therapy can produce a greater percentage LDL-C reduction and thus reduces cardiovascular events more than moderate intensity statin therapy. It also gives substantial long-term benefits on the prevention of adverse events after acute ischemic stroke without increasing the risk of hemorrhagic stroke. It also decreases the risk of stroke, major coronary events, and revascularization procedures. And finally, it gives more favorable early outcomes, suggesting an additional neuroprotective effect. For the monitoring parameter of dyslipidemia, we should first monitor the lipid profile, which include LDL, HDL, and TG, to ensure that it is at a normal level. Next, we should monitor the liver function tests, which include ALT, AST, and serum albumin. Finally, we should monitor signs and symptoms of increased creatine kinase, which suggests myopathy, which include muscle pain, cramping, stiffness, weakness, and fatigue. Now, let's move on to the pharmaceutical care issues and drug-related problems. First, PCI is the patient's potential medication adherence issue or insufficient control of diabetes mellitus with previous medications. This is because the patient's dextrose and HbA1c level were high upon admission, although the patient was on 3 diabetic medications previously, which were metformin, glycoside, and insulin mixed-on. Therefore, we should detect for adherence issue and assess the insulin injection technique of the patient. If the patient has no adherence issue, we may need to increase the dose of the insulin or change the regimen of anti-diabetic drug appropriately based on guideline until blood glucose level is controlled. We should also monitor the patient's blood glucose level and HbA1c, preferably once every 3 months. Also, we need to educate the patient to identify the signs and symptoms of hyperglycemia or diabetes, which may include increased thirst, frequent urination, and fatigue. The next PCI is the lack of ECG monitoring, although the patient had hypokalemia. According to Clausen and Catalyst, hypokalemia carries a greater risk of cardiac arrest than hyperkalemia. Therefore, repeated monitoring of plasma potassium and the electrocardiogram is important. To manage hypokalemia, first, repeated monitoring of ECG is required to identify any prolongation of the QT interval in the electrocardiogram. Next, we can give oral potassium tablet of IV potassium if the patient is not tolerating orally. Next, we should avoid drugs that can induce prolongation of QT interval, for example, antihistamine and antibacterial. As for the monitoring, we should monitor symptoms of QT prolongation, which include unexplained fainting, unexplained drowning, and unexplained sudden cardiac arrest.
Next, pharmaceutical care issue is unknown indication of antibiotic as there is no culture test has been done. According to CPG management of ischemic stroke, the appearance of fever should prompt a search for infection and appropriate antibiotic therapy should be administered early. However, the patient was given antibiotic without running culture and sensitivity tests beforehand, and thus the site of infection and the indicated infection is unknown. Based on the National Antimicrobial Guideline 2019, the general principle of antimicrobial therapy is to run the culture and sensitivity before initiation of empirical antibiotics, and then to adjust the therapy to targeted antibiotic therapy once the result is obtained. The patient had shown some upper respiratory tract infection symptoms before admission, but she was not diagnosed with URTI. According to a study, empirical antibiotic therapy is not recommended in treating URTI without accurate diagnosis, and targeted antibiotics should be given after the causative microorganism is known. This is important to prevent antimicrobial resistance in the future. The important monitoring parameters include bacterial growth from the culture and sensitivity, infection signs such as white blood cell count, C-reactive protein, ESR, and body temperature. One of the drug-related problems, the use of hydrocortisone in this patient poses higher risk than benefits. There are studies that show corticosteroids give no benefit in acute stroke, but it gives systemic effects such as increased blood pressure, increased potassium excretion, promote urination, and elevate blood glucose level. The management will be to discontinue hydrocortisone. Based on CPG management of ischemic stroke, if cerebral edema is present, we can suggest to elevate the head of the bed by 20 to 30 degrees to help venous drainage. Besides, hyperventilation can also be done with reduction of PCO2 by 5 to 10 mmHg, which can help to lower intracranial pressure by 25 to 30%. It is an emergency measure that acts almost immediately. As for the monitoring, we should monitor the signs and symptoms of cerebral edema, such as headache and inability to walk, and monitor serum potassium level and the input-output chart.
The next drug-related problem would be the concomitant of hydroxyprogesterone and tranexamic acid. Both drugs are indicated for uterine fibroid, however, precipitate blood clotting effect, therefore increasing the risk of stroke. Based on lexicon drug info, both drugs should be avoided in concomitant use. For management, it is recommended to discontinue hydroxyprogesterone as this medication greatly increases risk of blood clotting, therefore increasing the risk of stroke. However, if the patient's clinical condition improves, we should recommend the patient for a surgical procedure as both medication has risk for stroke. For example, hysterectomy provides a definitive cure for women with symptomatic fibroid, while myectomy procedure that resolves symptoms while preserving uterus and fertility, magnetic resonance guided focus ultrasound surgery, and uterine artery embolization. We should monitor blood coagulation profile, site of menorrhagia, and fibroid volume. The next DRP would be the inadequate dosing of potassium chloride on the first day of admission. The patient had potassium level of 2.5 mmol per liter upon admission and was given 2 grams of KCl equivalent to 26.82 mmol of potassium. According to Critical Care Pharmacy Handbook 2013, the suggested dose for oral KCl is 120 mmol per day. IV 60 to 80 mmol administered at 10 to 20 mmol per hour for moderate hypokalemia level. Therefore, we need to supplement additional IV 3 grams of KCl to the patient while closely monitor the potassium level 2 to 4 hourly until 3.5 mmol per liter. Besides, we monitor magnesium level, ECG, and heart rate of the patient. The last DRP is the prescribed medication that worsens hypokalemia. The patient is given augmentin, hydrocortisone, and insulin. Both augmentin and hydrocortisone promote renal potassium loss. However, high dose of insulin promotes shift of potassium from extracellular fluid to intracellular fluid compartment, and all these drugs lower serum potassium level. It is recommended to discontinue augmentin and hydrocortisone since both medication has no clear indication as mentioned before and worsen hypokalemia. In this case, insulin should be continued as the worsening of diabetes mellitus might promote more potassium depletion due to excretion. In this case, we should monitor potassium level, ECG, heart rate of the patient as well.
Now for the pharmacist intervention. The patient is taking many medications and she may confuse or forget to take it. Therefore, pharmacists should counsel the patient regarding to the medication use, especially insulin technique due to previous poor glycemic control, and provide aids such as peer box or medication identification chart.
Thank you for watching.